I have the honor and pleasure to introduce to you now Dr. Quentin Van Meter. He has come specifically for this event from Atlanta, United States, to London. Dr. Van Meter is a professor of pediatrics and an endocrinologist. His training in transgender medicine began in his fellowship years under Professor John Money at the Johns Hopkins Hospital. Dr. Van Meter has a private practice and he is president of the American College of Pediatricians. And one of their mottos is putting always the child's needs first.
First, I would like to thank the organizers of this meeting for inviting me. The CVs of the folks that have spoken before me are rather impressive. I'm just a regular old pediatric endocrinologist in private practice in Atlanta, Georgia. I have a long career, 44 years of practicing pediatrics and also pediatric endocrinology. And from that experience, I gleaned my worldview of patients and their problems. When the whole transgender issue began to surface in the past decade or so, I focused back on my memories of what I learned from my fellowship years. First of all, I would like to make a disclaimer on the part of the fact that I am a speaker for a pharmaceutical company, AbbVie Pharmaceuticals, who produces a gonadotropin-releasing hormone agonist. That is a blocker for puberty. I use this medication in my practice for the FDA-approved guidelines of suppressing precocious or early puberty in children. This medication becomes a very strong part of the transgender treatment programs, but in the United States it is not licensed for use, and my speaking on behalf of that product is not to sanction its use outside of the limits of the FDA-approved guidelines in the United States. I'm also involved in, aside from being a speaker, in clinical research studies with AbbVie. So the first thing I want to do is to look at the history of transgender medicine. There are what I refer to as the Three Musketeers. These are individuals who came on the scene in the United States in the late 1940s, 1950s, and 1960s, and they were three of them. The first one I'll mention is Dr. Alfred Kinsey, who began the Kinsey Institute in 1947. He had clinical studies that he did along with publications in regard to sexuality, human sexuality. There is a museum at the Kinsey Institute which chronicles a lot of his work. He also, attached to that, has a museum of erotic art which he collected. It's on display. His studies, most notably, included how children can be aroused sexually, and he did masturbation of males and females as infants, toddlers, and young children to see what results could come about. Next in line is Dr. Harry Benjamin. Now, understand Dr. Kinsey was not a physician. He was not a psychologist. He was an entomologist, someone who studies behavior and insect biology. Dr. Harry Benjamin was a family practice doctor who practiced primarily in New York City and who spent his summers in San Francisco with his family practice. He had a strong interest in allying with both Money and Kinsey to bring about new concepts of human sexuality. He was instrumental in providing medical therapy to Christine Jorgensen, who was one of the most notorious transsexual patients of the 1950s. Thirdly, John Money, who I knew personally and who I trained with in Johns Hopkins in Baltimore, was a graduate of Harvard, and he trained in psychology there. He was a clinical psychologist by licensure. He joined the Johns Hopkins faculty for a number of reasons, but most of them had to do with the fact that Johns Hopkins was the epicenter in the United States for clinical research and understanding of the biochemistry of hormone action in the developing fetus, which bring about either the male phenotype or the female phenotype. So he, at Johns Hopkins, had a population of patients that many other people did not have. Those children with what we refer to as ambiguous genitalia, and children who had precocious puberty, or some sort of hormone imbalance which mocked puberty but was not puberty, either coming from a hormone-producing tumor or some degree of hormonal dysfunction within the adrenal glands. Interestingly, in a biographic statement, he described himself as a pediatric endocrinologist, and he said he became one by traveling alongside of Dr. Lawson Wilkins, who was the preeminent and first pediatric endocrinologist in the United States back in the 1950s. Dr. Wilkins had a clinic with all of the patients that suffered from these various hormonal issues, and Dr. Money followed behind him, watching and observing, and by doing so claimed that he was, in truth, a pediatric endocrinologist. So we come to the term gender. It's a linguistic term, originally, categorizing nouns as either masculine or feminine. In French, le chat or la chaise. So it was not applied to human biology, and if you look in the medical literature prior to that time, only the term sex was used. John Money took the word to apply to what he called the inner sexed self. So we moved from there, and where we had basic human biology, that is to say, you were either male, XY chromosome, or female, XX chromosomes. The sex is binary. It is either male or it is female. There is a little tiny line between the blue rectangle and the pink rectangle, and that little tiny line represents disorders of sexual differentiation, a tiny, tiny fraction of the human population. Back in the day, they called these terms hermaphrodites or pseudohermaphrodites. Today they're referred to as disorders of sexual differentiation, under-virilized male or over-virilized female. It is an interesting concept that the trans activists blame the physician in the nursery or the Dell room for assigning the sex to the patient, as if that physician made a decision that was arbitrary and based on something that had nothing to do with biology. That sex was not assigned in the Dell room, it was recognized in the Dell room. Where it was assigned was at the moment of conception, either XX or XY. Now, we bring up the intersex problems or disorders of sexual differentiation. There is a concept of what's called a true hermaphrodite, that is an individual who contains gonadal tissue, both of the ovary and the testicle, because of a mishap in terms of division of cells. Both gonadal tissues are present in the same individual, and they vie for what kind of physical effects they have in utero. Contrasting that is the pseudohermaphrodite, so-called in the old terminology, who has the one gonad, and it's the gonadal tissue that belongs to their biologic sex. That is to say, a female whose genitalia are changed because of overproduction or over-response to what we call androgens, which are the hormones classified as male hormones. Androgens actually exist in males and females, but they are balanced such that one takes over and is predominant in the life of that child. The other option is a under-virilized male, that is to say a male whose genitalia and physical structures did not respond to the hormonal therapy. So in those cases in the newborn nursery where a baby is born and the genital structures are confusing in their appearance, and that cannot be classified and assigned in by the physician at birth, those kids are kept in the hospital until the chromosomal sex is determined. Now in the past, in my early days of fellowship, that took several weeks because of technology. It can be determined essentially in a day's time by specialized technology and looking for the presence of the Y chromosome or its absence. So those babies then are sent home as indeterminate necessarily, and the Committee on Disorders of Sexual Differentiation, national organization, indicates that the child's sex should be considered and assigned based on a combined team of physicians, surgeons, and the parents to determine what they believe is medically the best for the child. There is a very super rare subset of this disorder called androgen insensitivity disorder. It used to be called testicular feminization. This is a patient whose gonads are testicles, whose chromosomes are XY. but the patient has absolutely no receptors anywhere in their body, not in any tissue system, any organ system, that can recognize testosterone. And so, in utero, the baby's physical appearance essentially shows no signs of virilization at all. Now, the baby has testicles, which remain in the abdomen. The baby has a blind vaginal pouch, does not have a full vagina. The baby has no uterus, fallopian tubes. And that patient grows up appearing to be a totally normal female. The patient's brain has never experienced testosterone in the intrauterine environment to make any of its cells or the body's cell lines believe that the patient is actually a male. This baby is born and then discovered subsequently in young childhood if they herniate the gonadal tissue, or in adolescent years when they have no menstrual periods that develop, to find out that there are no ovaries present and that child, a young adult, is actually an XY female. And that child is labeled as such and grows up as a woman and has no gender dysphoria whatsoever. Those cases are extremely rare. A bit rarer than that even is partial androgen insensitivity, which is a genetic trait that occurs in certain populations in the world, most prominently in the Dominican Republic. And in those cases, the babies make testosterone, but they cannot convert it to the active metabolite, dihydrotestosterone. And they're missing an enzyme called 5-alpha reductase. Sounds kind of scientific and technical, but the bottom line is that when these children, who appear to be girls, and when they're born, get to puberty, the testosterone levels rise significantly and tissues begin to respond. And these children then turn physically from a female into a male at age 11 or so, when boys normally go into puberty. It's referred to as huevos once in the vernacular of the local population. In the Dominican culture, boys are worthwhile, girls are worthless. And so a family embraces the idea that their child would turn into a male and no longer have to be a female. And so it is culturally accepted. Again, a very rare circumstance. So we've got the male and female situation, and then we introduce, on top of that, the erotic sexual orientation scale that Dr. Kinsey developed. Now, this is a scale that you can see, if you look on the slide, on the left is blue, and on the right is pink. And that is a scale that evolves across, as was spoken of previously. There is not a fixed concept of one or the other necessarily, but there is a scale across which humans end up orienting themselves erotically to somewhere on that scale, and that scale is fluid and can change over time. Now, we add on top of that something in the middle, and that is gender. Gender is John Money's term, and John Money used that to describe the inner self. And if you can see, what we have here is a blend from one side of blue to pink, and most notably, in the middle is a gray zone or a white zone, which is neither male nor female, sort of a non-gender identity at all. So this is where we are using terminology today. What happens then is the concept of erotic sexual orientation is its own place, male and female is its own place, and what remains then strictly is simply gender. So gender then, as described by John Money, is a state of mind. Gender is not biology. So we want to talk a little bit further about John Money because, having experience working with him, I have a fairly strong feeling about his concepts and ideologies. John Money used to say, "I have an idea. Let's do this and see what happens." Now, this concept of intervention violates the Nuremberg rules that were established after the Nazi Holocaust in Germany, because there was a set of rules that were established that protected patients from being abused, and it laid out in the consequences of what happens if those things happen and the patient is abused. There was no informed consent in John Money's concepts. There was no ethics-based oversight. There were no control groups in what he felt. He felt, I want to do this to the child. I think this is going to happen. Let's do it, and we'll hope that what I think happens will happen. So some of his more famous interventions were medical castration of adults. Now, castration, removal of the testicles, was not considered an option, a legal option in the United States. But if you could give something to male sex offenders that cut off the stimulation from the pituitary gland to the testicles, that would drop the secretion of testosterone naturally, but it would leave the testicles intact. So it was a non-surgical option to give those male patients Depo-Provera. Depo-Provera is a very commonly used oral or injectable contraceptive in the United States and worldwide. In the males, this basically suppressed their production of testosterone. And as long as they were suppressed and their testosterone levels were low, their sexual behaviors became more diminished and their aggressiveness became more diminished. So this was done, again, without any thought other than it was used to suppress puberty and precocious puberty at that time because we did not have the more current therapies, and he used that essentially as a tool to medically castrate adults. One of his patients, when we were endocrine fellows, we often would get a call from Dr. Money's office, and we were pretty much always worried what was going to have to happen as a result of that call. Dr. Money asked for the fellow on call, which happened to be me that day, to go over to the penitentiary in Baltimore and examine a medically castrated adult who was taking Depo-Provera. The patient claimed that he was having breast tingling sensations, and Dr. Money wanted to know what that was all about. I got to the prison, got locked inside, went into the infirmary. I hope it's the last time I ever have to be locked into a prison. And I ended up examining the patient after I had a chance to get a history from him. And he described his life in prison as being very interesting because it flowed with the effect of the Depo-Provera shots. At the end of the month, he would feel his testosterone levels coming back up, and he said, my sex life in here is pretty good, as long as the Depo-Provera wears off. I didn't ask him what pretty good meant. I just left that one alone. And I did the physical exam and found absolutely nothing on his breast exam that would end up indicating there was a medical problem, and reported that back to Dr. Money. Subsequently, medical castration of sex offenders has been stopped as a practice. The other things that Dr. Money did were switching gender of children with ambiguous genitalia. And this, again, was one of his theories that he decided to try, and he had support of the surgical teams who would help after the patient was born to modify the appearance of the external genitalia. It was a combination of GYN surgeons and urologists who developed techniques to remove the enlarged clitoral structure and create what looked like a normal clitoris in a virilized female, to open the vaginal opening appropriately, to expose what was beneath and was anatomically normal, and to carry the patient on from there. He also ended up in a case of a child who had his penis accidentally burnt off by a botched circumcision. He decided that that baby needed to be reared as a female. That baby was reared as a female with Dr. Money's support from his staff, and we didn't have to do any hormonal manipulation, but the baby's testicles were removed as part of the surgical procedure, and a vagina was created as a blind pouch in the genital area. That patient had to undergo dilation of that vaginal structure through young childhood, not knowing necessarily why as a 3 or 4 or 5-year-old child. And the child began to have issues with severe depression and anxiety that mounted to the point where the therapist recommended to the parents that they tell the child that she was indeed born a male. And that patient immediately indicated, once he knew that he had felt something was wrong the entirety of his life, and that had essentially caused the anxiety and depression for him. He ended up having a little stub of genital tissue, of penile tissue, that could become erect so that he had some degree of sexual activity and satisfaction as an adult male and became married. And then he tragically took his life. So that patient became the cause célèbre in terms of undoing what John Money had been doing all along. My own personal experience with John Money was toward the end of my fellowship, with a little patient that came from out of state, again to what we referred to as the medical mecca of disorders of hormones. This was a baby who had absolutely normal male structures, had a scrotum, had testicles, had a penis, but it was all very small in size. The chromosome of this baby was an XY, as expected. And this baby had what we now call hypogonadotrophic hypogonadism. That is to say, the brain was not signaling to the pituitary to change the genitalia from small to normal size at birth. Under the influence of the mother's placental hormones, this baby, who was a male, was able to virilize and produce all of what he needed from his own biologically active testicles to make his structures male. Being a male anatomically is a very active process in utero in the first 12 weeks of life. If there is no stimulation by testosterone, everything lays dormant and appears to be female at birth. So this baby was not ambiguous, this baby just was understimulated. And our theory was that we wanted to prove that that was the case. Now, we were kind of excited because Dr. Money happened to be out of the country, or so we thought, and we did not have to have this patient intervene or be interviewed by Dr. Money and his staff. So we developed a protocol which was based on sound science to stimulate this baby's testicles with hormones and to see whether or not, number one, the baby could produce testosterone, and number two, if the testosterone brought about physical enlargement of the penile structure to the point where it would be a normal newborn size. We developed the protocol. It was based, again, on clinical experience and our knowledge through literature. We sent the baby home on that protocol, which took 6 weeks and happened at home. And the baby came back. When the baby came back and it was scheduled in the clinic, I noticed that instead of his name being a male name, it was a female name. And that puzzled me a little bit. So I walked into the room, and here was the former little baby boy in a pink frock smock gown and a white eyelet bonnet. And the mother looked at me, and I said, "What happened? How did this happen?" And she said, "Well, Dr. Money met with me before I left. He evidently got back in town, and he was able to come talk to me, and he said, the medical therapies that these doctors are going to do for your child are barbaric and inappropriate and will not bring about any change at all. They do not know what they're talking about." So, Grandma was along with Mama, and I undiapered this little pink-frocked child and found an erect penis that was clearly a normal size and testicles that had developed to normal newborn size. And at that point in time, my attending physician had it out with Dr. Money, and Dr. Money was removed from access to our patients thereafter without specific permission of the chairman of the endocrine division. So that ended up being one of the things that brought Dr. Money's program to a close. Dr. Money, in adults, decided he was going to do a transsexual clinic. This is what it was not called transgender back then, it was called transsexual. And he recruited adults who thought they wanted to change their sex, and he would bring them in, evaluate them, and then he would basically make them cross-dress for a year and assume the role of the opposite sex. The vast majority of these were men who indicated they thought they were going to need to become women. They would cross-dress for a year, and then he would make sure they had a bank account, a savings account, that had money in it to be able to pay for some of this kind of therapy that was going to go on, primarily as an anchor point for them to be committed to stay with the therapy. So it had two purposes. The therapy was done essentially for free, but the money sort of made them convict themselves to sticking with the program. After that year, and the bank account being full, and they also had to have no record of being arrested for prostitution. Most of these males were on the streets dressed as women and were having sex with men as a lifestyle by choice. And so they had to have a clean record of no arrests. And then the surgeons took over and amputated the male genitalia, amputated the breasts in the women, who were few, and created these transsexual adults. So his experience there was that the patients, for a while, felt like they had made the right decision. But they lived their lives as caricatures of women, not as a standard adult female. They were very flamboyant, incredible amounts of makeup, again, looked like streetwalkers for the most part. So it was judged to be not a program that brought about reasonable outcomes. Now, John Money also had a lot of issues with perverse behavior. In the clinic, his psychohormonal clinic, the interviews with the patients were interesting. One particular case that I saw was a boy who had a testicular tumor that had caused a lot of testosterone production. And this little boy had an adult-sized penis at age 6. And we discovered, it was fairly easy to figure this out, one testicle was extremely large and the other testicle was not. And that large testicle, there was a definable tumor mass that you could feel. Dr. Money asked this boy on the initial evaluation, all of these things were dictated and then transcribed into typed notes for us to stick in the endocrine record so we could read them and see them. He asked the boy how often the boy masturbated. He was a 6-year-old. And the boy indicated he didn't know what that was. So Dr. Money took a pencil and started stroking it, showing him this is what happens when you masturbate. And that child left. The next time he came to the clinic, he was interviewed by Money again, and this time the transcription said, asked how many times he masturbated. The boy was masturbating 6 to 8 times a day. So this was a situation where basically this boy was taught how to masturbate, which would not have happened outside of Dr. Money's influence. He also taunted female fellows. There were 2 in my group that trained around me who were fairly devoutly religious people and that was fairly well known about them. And Dr. Money did everything he could to offend them in every way with his lectures and how he treated them and how he affronted them with foul language and pornographic images in his teaching sessions. My favorite circumstance was a lecture that he gave. He had not created teaching slides yet, so he just had a notebook of crude pencil drawings. And he had theorized that amputees had the sense that their stump of the limb was actually a phallic structure that could be masturbated in fantasy. And he presented this to us as one of his new theories. I, being fairly brash and young at that point in time, raised my hand and I said, Dr. Money, I don't know what to say about this, but I trained in my pediatrics at the Naval Hospital in Oakland, California, which had the National Prosthetics Research Laboratory, which was essentially a place where Vietnam veterans who'd come back with damaged limbs were fitted with prosthetic limbs, hands, feet, whatever, and that they had a whole stable of these patients that were close by our pediatric ward that we got to meet these folks because they'd be in the elevator, in the hallway, in the wheelchair, and we chatted up with them. These folks that had amputations were evaluated completely from stem to stern about the psychological stress of adjusting to their limb amputations. And not once was there any theory of a sort of a dream of masturbating the stump. That was not essentially valid science from experience. So I mentioned that to him. He folded up his notebook and said, well, we're done today. And that theory disappeared. So that was kind of how he did things. He just sort of essentially had an idea, threw it out there. If somebody believed in it, he'd carry on with it. So I was able, at least temporarily, to stifle that theory in Dr. Money's teaching lectures. And lastly, when he wrote his books, and he was a prolific author, some of them were revered as sort of a Bible of human sexuality. He called up one day, again, he wanted to speak to the fellow on call. Again, lucky me, I answered the phone, and he said, Quentin, I am doing a new book. Tell me about gonadotropins. It took me by surprise because I figured he'd been around endocrinology and he certainly should have known all about endocrine physiology by now. So I kind of gave him a quick synopsis, and he said, thanks very much. And then he used that in his book. Now, that is the depth of the research of the man, and that's why I think historically it's important to pay attention to where the idea of transgenderism came from and sort of handle it that way. So, Dr. Money's legacy. He failed to achieve good clinical outcomes. He had the patient who committed suicide. Dr. Paul McHugh arrived in 1980 or 82 and found the disarray in Dr. Money's psychohormonal group. And as chairman of the Department of Psychiatry, he closed the program down in utter shame and said, "We will never do this again." Now Dr. Money, one of his legacies that lived on past his experience of being on the Hopkins faculty, is that he began, or was instrumental in beginning, what was called the Harry Benjamin Society. Now, the Harry Benjamin Society was named after Dr. Benjamin, who I mentioned before, and it was essentially an interest group. It was something that came together with people who were interested in transsexualism or transgender medicine. And it was just an interest group. It was not a professional society at that time in terms of training or expertise. It was anybody that had a desire to express their opinions or in support of transgenderism or transsexualism could become a member. Now, the Harry Benjamin Society was viewed in the United States as kind of a super fringe, crazy bunch of folks. It had no basis in medical science. It was not accepted by mainstream organizations at the time. And so it was essentially thought of as someplace you wouldn't go if you were looking for valid medical treatment. The Harry Benjamin Society sort of disappeared, and in its place, it sort of was the basic organization from which the World Professional Association of Transgender Health arrived. Now, the WPATH is an organization, again, with essentially the same concept. If you are a friend of transgender, transsexual patients, this is where you want to come. Again, no degree requirements to be a member, no certification with medical training, and no degree of any kind. And if you look at the people who sign on behalf of the WPATH, it's everybody from physicians and mental health providers to just plain interested people. Membership requires that you be interested and that you pay your dues. So we see the decline of the effect of the Harry Benjamin Society, but in its place, a very more proactive kind of group. The bibliography that the WPATH puts together to claim its science, if you will, is actually a very substandard bibliography. It looks numerous. It's got about 150 items in the bibliography, but it is mostly anecdotal case reports or re-reporting the same information over and over again in different little journals around the world. And so if you look at some of the references that they choose, they're actually nothing to do with transgenderism at all, but many times to do with homosexuality. Now, transgenderism is its own unique diagnosis and clinical circumstance, but it is blended in by the LGBT activist community as if it's part of the brotherhood. The WPATH is, I call them on the warpath. They have essentially created their own science, if you will, and they have their own journal. It's the International Journal of Transsexual Health. And so that is a journal that publishes favorably articles about their agenda, political agenda. So let's look at the timeline about what's happened with transgenderism over time. Prior to the 1970s, essentially all the transgender medical care was done in Sweden and Denmark. That's where Christine Jorgensen went for the surgery changes. In 1950s, 60s, and 70s, under Johns Hopkins, the transgender clinic or transsexual clinic was sort of done through the mid-70s. And all along in the Scandinavian countries where this concept was accepted, there was a very strong social acceptance of transsexualism or transgenderism by the community, by the government, and by the healthcare services. In the 1980s, everything went underground. And in the United States, the major medical associations had nothing to do with transgender interventions other than recommending counseling. So in the US, you could not find anybody to go for transgender health unless you went to the Harry Benjamin Society website, which back then was not yet WPATH. And you would find a list of willing surgeons and willing physicians who would give hormones and who would do surgical treatments. This was all done under the radar, so people didn't know that that was going on necessarily, but the people who wished to be transitioned physically knew where to go, and they did go to those places. In the Canadian situation, Dr. Kenneth Zucker began his clinic under the Institute of Addiction and Mental Health. And he actually had experience taking these patients who were age 5 and on up through adolescence. And he delved deeply into the basement of cobwebs and all the psychological problems that Dr. Van Holt talked about with her patient, and found that if you went down into that deep and dark place and you shed light in there and you brought the patient through the transition of understanding their internal feelings that had been broiling and broiling around, that they would essentially return to their birth sex as an identity by the time that they were through therapy in the vast majority of patients. He had experience over those years with 560 patients. He's published his experience and the guidelines for treatment and evaluation in respectable medical journals. And he was essentially looked at as the guru of gender identity disorder all the way through the 80s, pretty much worldwide. So he provided care, much needed care, for the very small, relatively small number of patients that came from around the world and came to Toronto for his help. Meanwhile, back in Sweden, Denmark, Belgium, and the Netherlands, they were treating adults medically and surgically, and eventually began treating children medically and surgically as well. So in the early part of my practice, once I retired from the Navy in 1991 and came to Atlanta to practice medicine as a pediatrician and endocrinologist, in 1993, a patient came to my office. It was a family that moved from California. They were active duty military, and they moved very frequently. And this child came to me as a girl, and the parents confided in the exam room that indeed the child was a boy, but had believed that he was a girl, and he had consulted a psychiatrist in Los Angeles area who had indicated that the family should use the move to Atlanta as a means to change this child's identity sexually and raise that child as the girl that he wanted to be. So no one in my office other than my nurse knew that this patient was not a female. And I was asked to treat this patient because he was now 13 and he was developing well into mid-puberty with estrogen to stop his puberty. And I did not know what to do. So I called all the gray hairs that I knew, and I speak of gray hairs fondly, but the folks that I trained under and who were still around, and I said, what do I do? You know, I have not seen a single patient, transgender patient, since my fellowship days. I know of no one in the clinical world that I can go to, except for you guys who've been around long enough. What do I do? None of them had any answers. There was no experience in the accepted medical community about what to do for this 13-year-old boy. So I was advised, well, if the psychiatrist is an expert, and that's what the psychiatrist says, let's go ahead and get him started on estrogen. So I developed a protocol with legal backing for informed consent with the parents and assent from the child to cover myself from future legal action against me, and began the child on estrogen. The family moved again very quickly, within 6 months, and they were gone. They moved to another city. I notified the folks in that geographic region that the family was moving there, and that I was hoping that they would end up being able to pick up the ball and go with the therapy. No one ever heard from the family that I know of, and I do not know what happened to that young man who was taking the estrogen that I prescribed. It was not a zone of comfort for me at all. So imagine my surprise when all of a sudden in 2007 and 8, I begin to see articles showing up in the standard pediatric journals about kids with transgender issues. It turns out that in 2006, Dr. Norman Spack from Boston, who's a pediatric endocrinologist, went to the Netherlands and decided he was infatuated with the idea that transgender treatments could be done to children. So he established his own transgender clinic in Boston after he came back from the Netherlands, and that was the first official transgender clinic in the United States. In 2009, the Endocrine Society, a major American medical group of academic endocrinologists, got together a working group of 10 individuals, all of whom were trans activists, none of whom had any contrary opinion, and they developed the guidelines for care of transgender persons. Now, at that time, again, there was a Boston clinic and maybe a Los Angeles clinic. And so we had a very limited number of places to go, but the guidelines were very clear. Affirmation was the way to go once you evaluated the patient's psychological issues, and that you trained the family how to accept it and counseled the family. At the onset of puberty, you blocked puberty with hormone blockers, the GnRH agonists, and you could interrupt puberty and hold it, and then introduce cross-sex hormones within a couple of years, and transfer the physical appearance of the body to that of the opposite sex. And at the age of consent, 18, you could have, the patient could choose to have their genitalia removed or their breasts removed and other structures constructed to try to appear as if they were the opposite sex. These were the guidelines from the Endocrine Society. They were initially published to the membership for review. I sent in a strong protest. I don't know how many other people did, but I had my own clinical experience with Dr. Money, and I felt very strongly about it. And I got no feedback that my input was considered at all. And the guidelines were then published. Now, the guidelines are interesting. In the original 2009 guidelines, there were 22 recommendations. And in the world of science, there is a system called GRADE, G-R-A-D-E, and I can't remember what all the initials stand for, but it is a system to rate the scientific basis of the evidence on which the recommendations are made. One circle filled in indicates there is no scientific basis whatsoever. Two circles colored in indicate that there is maybe a little bit of evidence, but is considerably weak. Three circles indicate that there's a moderate amount of scientific evidence, and four circles indicates there is profoundly strong evidence in medical science and research to support the recommendations. Of these 22 recommendations, 3 had 3 circles, indicating moderately appropriate scientific background. All 3 of those recommendations were that there should be research done, essentially on the effects, potentially, of cross-sex hormones and blocking puberty. The remaining 19 were split even between 0 evidence and scant limited evidence of a basis for which the recommendations were made. So all of these were put forward by an Endocrine Society committee and published as a standard of care against, I mean, who knows how many of the members of the Endocrine Society, myself included, had a chance to have their opinions reviewed in contrast to what the recommendations were stated. But nonetheless, they were published, and from 2009 to 2014, the number of transgender clinics in the United States rose from 2 to 42. Now, did the incidence of transgenderism increase by that almost logarithmic type of advance? No. But the guidelines essentially set things up for academic institutions to create a clinic to conform to these new politically correct guidelines. And it was essentially unofficially stated that if you didn't go by those guidelines, you were a transphobe, and you were to be basically sent to the sidelines and shut up. So that did not settle well, but the transgender clinics flourished. And in 2017, these guidelines were revised. There were now 24 guidelines instead of 23. This time, only 4 had 3 circles, the same original ones, and an additional one that said that the patient should be counseled about the inevitable sterility that would happen due to this intervention. Kind of shocking. They lessened the emphasis on basic psychological evaluation. They lowered the age for cross-sex hormone recommendation and suggested that if the patient wanted to have earlier surgery than age 18, that could be considered maybe at age 16. So since those recommendations were published in 2017, we now have 55 transgender clinics in the United States. And this is any organization that is part of a children's health consortium at the university level vies for getting points to be the best children's hospital healthcare system. And one of the points you can get is if you have a transgender clinic that actively affirms patients. And they ask for numbers, and if you have the right numbers, you get extra points, and you rise in the ratings for the best children's hospital in the United States, and the U.S. News and World Report annually. So this is a very perverse kind of situation where we are essentially using politics and social pressure and not basic science to look at the quality of medical care. So not to be outdone, the Pediatric Endocrine Society did its own set of guidelines. And if you look at the original Endo Society guidelines, the committee was made of 6 folks from the Netherlands and 4 folks from the United States. It was composed of 6 adult endocrinologists and 4 pediatric endocrinologists, making recommendations about pediatric endocrine issues. And we're talking about adult endocrinologists understanding puberty and growth and everything, which they never deal with clinically. They're always dealing with patients who are essentially fully mature. And they were the majority of the people on the committee that helped get these guidelines going. 2 of these individuals on that committee were former students of John Money. So, was there anybody on that committee, such as Dr. Paul McHugh, who understood everything and was widely respected? Nope. Was Dr. Kenneth Zucker on that committee? He wasn't an American, but he was excluded from that committee. So they carefully chose the guidelines and published what they wanted to. Now, not to be outdone even later than that, just this past September, last month, the American Academy of Pediatrics published guidelines for transgender care. They eliminated any reference to the need for psychological evaluation of the child. The only psychological issues were counseling the parents to accept their child's new gender, and that they had to do the counseling because the parents would otherwise be resistant, perhaps. They mentioned nothing at all about the medical concerns, and they basically spent time looking at government policy in terms of covering the insurance it needs for the children who needed puberty blockers. To do puberty blocking, we're talking in the United States about $20,000 per year of treatment, and it's not covered by insurance. So the lobby from the American Academy of Pediatrics, an organization of 66,000 pediatricians, pretty strong numbers, came up with these guidelines. Who wrote those guidelines? Did the 66,000 members of the American Academy of Pediatrics approve those and review them? No. A committee of individuals, 10 in number, and the executive board of 12, and some other individuals gathered together, a tiny fraction of the membership, wrote the guidelines and approved them without the membership knowing. Unwittingly, the membership looks at their parent organization and says, this is my professional organization. They say this is what it should be. I don't understand it, but clearly I don't have any training in this, therefore I will accept those guidelines and carry them on. So in the process of this whole burgeoning of transgender medicine, the incidence of true transgender or gender dysphoria rose in males from 0.06%, that is to say, 6 out of 100,000 males suffered from gender dysphoria, and 3 out of 100,000 females suffered. It now has been quoted, as of last week, that 1 out of 4 kids in high school has issues with transgenderism. So we've gone absolutely crazy. In the same process, there's a beautiful graph, which I meant to include and don't have here, that shows the incidence of transgenderism over decades and the rise of transgenderism since the onset of Facebook, Instagram, and other social media on the internet. And what has happened is that the incidence, instead of being 2 to 1 male to female, is now 2 to 1 female to male. And that has happened because of social phenomenon and social contagion. Clearly not based on biology, but clearly based on sort of an hysterical, almost religious cult, if you will. So we have an issue then with politics trumping science, and that's where we are with transgenderism today. There are 3 areas that of concern. One is the belief in transgenderism. It is literally as if it were a religion. It's not based on science, it's based on belief. Now, the world's religions are based on belief. and sometimes have some corroboration in science and history that's very, very important to those who believe. And those situations are not castigated. We don't cast aspersions on the fact because they have a particular religious belief. We allow them to believe that, but we do not allow them to go and have laws make us accept everything about them and change our lives to go along with their beliefs. So imagine if Roman Catholics decided to get a law which said, all of you in this room cannot eat fish on Fridays during Lent. That all of you in this room must go to confession at least once a year, and preferably more. You all must go to Mass on Sunday. And that if you don't, you are showing absolute ridicule and distrust and Roman Catholicophobia if you don't do that, okay? So, I mean, just it's a parallel that no honest, sane person would ever believe is within the rights of individuals to be who they are and who they believe they are. So if a trans person wants to be trans and believes they're trans, we would suggest the kinds of therapy that we know do work, but we would not treat them as second-class citizens. We would not show them a lack of compassion. We would say to them, we understand that you are miserable and suffering deeply with what's going on, and we would hope that you would get to some therapy. But please do not make me have to look at you naked in a men's room if you're a woman, or as a teenage boy in a female dressing room naked in that stage of life. That is an imposition on my individual rights, okay? And so I don't feel that the government should tell me that I have to do that. So it's basically the concept of it being foisted upon us as a state religion, if you will. Now, the medical societies have the guidelines, and I've already mentioned those, and the Diagnostic Statistic Manual of Mental Disorders, DSM, has basically taken the concept of gender identity as a disorder and removed it as a disorder. And in some ways, that seems to make sense. And they wanted to cover the suffering that was going on and describe the suffering, so it became dysphoria instead of a disorder, because a disorder is a very specific term in mental illness, that if you are persistent and having issues that cannot be changed, that are not real, that becomes essentially a delusional disorder. Before that, you have maybe some delusional thoughts or some thoughts that are not in touch with reality. So making everybody identified as a disorder when they are in transition of trying to figure out who they are on the gender scale should not be essentially placed as a negative term. So I agree with what happened, and that was very carefully thought out by the DSM. And Dr. Zucker actually chaired the committee that brought in the term gender dysphoria. So the third place that it happens, or second place that it happens in terms of political pressure trumping science, is in government regulation. As I alluded to for the gender bathroom bill in North Carolina, where it went all the way in the court system, it was stopped when the state legislature withdrew the bill for reasons that it was a non-issue. The state of North Carolina was castigated by major corporations who were activists, that they would take all of their business out of the state and cause the state to fall on its knees financially unless they passed the bill that said the bathrooms can be visited by anybody of any gender just based on who they felt like. So there's pressure for local governments, there's pressure all the way down to school boards. The city of Decatur in Georgia, it's a suburb of Atlanta, passed a regulation without parental hearings that all bathrooms and all locker rooms were unisex. And that fell on its knees with a huge response from the parents who decided that was not the right thing to do. But the governments all the way down to the local level are putting these concepts into effect through regulations and laws. Another aspect of the politics trumping science is in academic medicine in terms of appointments of faculty and publications. So if you publish something that is essentially questions transgender as an innate biologic event and concept, then you will be removed from your faculty position if you're not tenured. And if you are tenured, you will be essentially not allowed to get grant money for the same reason you will be left unpublished, because the journals will not publish what you are trying to do. The most recent case of that was an article in the online journal, PLOS, by Dr. Lippman from Brown University, who described rapid onset gender dysphoria in females and interviewed 270 patients, parents, and families about how this occurred, to basically show it was an internet-based hysteria phenomenon that caused this to happen in these girls. And it was withdrawn by Brown University, and Dr. Littman was censured by the university for doing so within a week. So it drives other people, such as Dr. McHugh, who is a world expert, into publishing wherever he can. Dr. McHugh had written a long thesis that was beautifully referenced. It's kind of like eating really rich fudge. You cannot sit down and digest it all at once. You have to go back again, and you kind of think about it, and then you go back again and read another section and digest it mentally, and you go back again, and it is a thorough evaluation of the lack of biology in same-sex attracted individuals and transgender patients. And he wrote this and referenced it, and then he said, I can't get this published, so I want to have somebody else who is an LGBT activist come and review this and point out to me all the places where I've shown personal bias or bias in any way that was not intended based on my religious faith. I want none of that in this paper. I want this all expunged. I want you to show me what in the world is wrong with this paper, because I know if I do it right, it could be published. So he enlisted Dr. Lawrence Mayer, a psychologist and a statistician and bioethicist, to review the paper. Dr. Mayer was an LGBT activist, very strongly feeling about the rights of individuals who had same-sex attraction and discrimination against them. And so he read the thing, and he got into it, and he said, oh my God, this is incredible. What you've done is you've unearthed the fact that 40% of same-sex attracted adults have severe or moderate depression. And no one is paying attention to this because it's not politically correct to bring that up. That would inherently mean that there was something that was an internal struggle with these individuals, and we just can't have that. So Dr. Mayer put his imprimatur, he actually became the lead author of this paper, put his name on it, wrote the introduction and sort of the executive summary. And within 1 week after it was published in a journal called The New Atlantis, a journal which is a sort of a quietly erudite journal that is not reviewed by a panel of peers, it was completely, totally lambasted in the medical press in the United States. There was a letter to the editor of a major newspaper signed by 600 medical professionals, so-called. It was a cut and paste list from WPATH. And within a week, they said, this is trash, this has no basis, this is absolutely hideous, this is a right-wing Catholic conservative psychiatrist who should be removed from Johns Hopkins as an emeritus professor and sent packing in shame. We will have none of this. That was published. I went through 10% of the list of authors of that letter, and it was not personally signed, it was just names on a list. And of that 10% that I looked at, and that was 60 names, I found one pediatric endocrinologist, several psychologists, and a bunch of names with no degrees after them. So these were the medical professionals, so-called, who said this paper was absolute trash. They obviously didn't read it, because when I read it, I got through in a week, maybe a third of it, and then I went back and I reread that again. Okay, so it's one of those things where it was an instant knee-jerk response, and everybody jumped on the train, and it made national news. And there was pressure from Johns Hopkins to actually remove Dr. McHugh from the emeritus faculty. They didn't do it, but they just kind of looked the other way. And in the meantime, they established their own transgender clinic at Johns Hopkins and advertised that proudly. So that's what we're facing here. We've got research studies that are designed to basically prove the point they want to make. So the transgender activists in our country got together in Seattle, a group that has a transgender clinic there, interviewed their trans-affirmed children, and they interviewed those that essentially from the families in their clinic that volunteered to be part of the interview process. Not every transgender patient, just those that had an interest in filling out the survey. And they found that 100% of these children were happy and well-adjusted at the end of the first year of affirmation. Now, who did the evaluations? Who filled out? The parents. This is no study that should be published. It means absolutely nothing. It's totally biased in terms of selection. It has no control group that was part of that to be interviewed, to compare. And yet it was published immediately in the journal Pediatrics, which is the voice of the American Academy of Pediatrics. So that gets published and then referred to over and over and over again over this past year as a valid scientific study that completely shows that affirmation of these children is the way to go. So beyond that, we are fighting a new study from NIH, which is National Institutes of Health, designed specifically to show essentially the same kind of results. This is experimentation on children without informed consent. These children do not know, were not told that they would be sterilized. And if they chose to be sterilized as children at age 12, 13, and 14, how many of them understand being a parent or procreating or raising a family in their future? Not very many of them. So that's the state of where we are. It's a dangerous situation. We want to fight the fight because it's important for us to continue to prove what we really believe, that we have to recapture the language using the concept of trans female, meaning a male who becomes a female, because you can't change sexes, you can change gender identity, should be a trans-identified male. And we should talk about sex maintenance therapy versus conversion therapy, because what are we converting? A biologic male into a biologic male? That's not conversion at all. That is essentially a concept of regaining who you really are biologically. We need to remove gender and replace it with the word sex on government documents. It's interesting that when I left, I just checked my driver's license in Georgia, and we're very enlightened in Georgia. We have sex, male or female, on the driver's license. Delta Airlines, on the situation where they want to know when you're traveling internationally, has gender. The form that I filled out to enter the UK had gender. So these kinds of things slip in and become valid as a concept when there really is no basis for that. And I'd like to close with the concept that nouns have gender and people have sex. Thank you very much.